Thank you. All right, so I'm going to invite the three speakers up to the table at the front. And I'll also, as time permits, because I know these presentations were influenced by the entire work group, as I see work group member hands sort of go up to help clarify something, I'll try to recognize that as well. I know that our first question actually comes from online. So Stephanie, why don't you tee that up for us?
Sure. So we have a question from our online viewers. Are we encouraging researchers to develop a singular application for this cohort, or will the participants have to have access to multiple applications for various conditions?
One of our core recommendation was that everybody in the cohort have a mobile phone, a smartphone, and a watch. But they also have the encouragement. We have the design of the system has got both open APIs and open permissions and policy to encourage people to upload anything that's available to them. So if you think of 10,000 apps and they're using one, why wouldn't we ask them to supply the data from that app to our data source? So the way we look at this is that we couldn't possibly recommend 1,000 of the 20,000 apps be used, nor could we know what app is coming after the next version 2.2.3.4 of whichever one all of a sudden becomes very valuable. So if we have people contributing what they find useful, and we encourage that through open APIs, policy, and permissions, and make that a core component of the recommendation, then any app that turns out to be useful will quickly bubble to the top and we can accelerate it. Same true for sensors.
So lots of people. Francis, we'll start with you. And
So interesting presentations, and I want to ask about the way in which all of these applications have actually been subjected to what you'd want to see, which is sort of rigorous assessment about whether they improve outcomes. Because my sense is we've got tens of thousands here of cool ideas. And yet if you look at the literature, how many publications can you identify where any one of these has actually been subjected to a rigorous analysis of whether people who use it actually, besides having fun, enjoy better health as a result? Where does that stand? And is this actually a role for the cohort to provide a platform for more of those studies to be conducted?
So that's an excellent point, and I know that this was an issue when we were talking about getting mHealth advanced a few years ago in terms of into the Common Fund. I would say, again, as a journal editor and somebody that's been doing research in this area, the literature is maturing. Text messages, for example, evidence-based around smoking, around other areas. I mean, the evidence is emerging. Remember, this is a pretty early field. We really didn't begin research in mHealth in a serious way earlier than 2004, 2005, and so it takes a while, as you know, to get the grants through your institute to get them funded. And Bill Riley has actually commented on this a lot about how long it takes to do this and how quickly the technology changes. So again, I would say again, some of the foundational issues, we found, for example, some good evidence that Facebook and one of our, that using social media is useful. Again, this is emerging from a variety of fronts. So I think we're going to see some really good review papers, potentially Cochrane reviews, others that will support this. But one of the exciting things, building on your second point, is that we have needed another method of science, because again, a lot of us are talking about how the typical randomized controlled trial doesn't work as well for technologies that require continuous engagement 24/7, because that continuous engagement, when used as directed for some of these things, shows profound results. The challenge is getting people to use these as directed in some way in terms of this. So I would say that what's exciting about not only this cohort, but the whole approach that we're talking about new evaluations, is that new study designs, new approaches will allow us to understand the utility and for whom these work and for whom they don't work sooner, so that we can change and adapt the intervention to what it is that they may need. So that's my answer.
I think we can guarantee that most apps are snake oil, right? Just like most articles in most self-help magazines are full of nonsense, right? They're just not based on science. They're somebody's conjecture or whatever. But the new science is what I think matters here, that this is a agile method that we're getting into as opposed to a waterfall method. So this is something happens, a little change, something else happens, a little change. If the app works, this system of collection of data will be able to figure that out a lot quicker than anything else based on the sensors and the input and the rest of it, right? So there's one of the best ways to figure out what works and what doesn't work is the system, this platform we're talking about itself. And we tie it back to science. I mean, that is the basis of this, and figuring out the genetic basis of disease and whatnot. I think we're going to discover things, as with any new measurement method that's pervasive. We're going to be able to discover things that simply we weren't looking for, and obviously be able to instrument things in ways that we couldn't before as well.
So I'll try to make just 3 quick points on this. So first, clearly by inclusion of mobile health in this room, as well as all those tens of thousands of apps, they signal interest and promise and potential. Second, that thus far, a lot of the role for mobile health technology has been monitoring when it comes to real actionable healthcare. And but the third point I would make is, but mobile health technology also offers an opportunity to deliver intervention and adapt in real time. Those are promise and potential only and have not yet been converted to reality. This cohort, by providing this measurement on this such large scale where we were limited to tens and hundreds, this is going to provide the opportunity where the gold standards will emerge.
I see lots of hands. The hands that are related to sort of reliability, validity, efficacy testing. Jeffrey, start with you, and we'll kind of work my way. It looks like a lot of people have
Jeff Ginsburg, Duke. I think Francis' questions is about outcomes is another way to talk about clinical utility. But I think my opinion is that these types of technologies, like other devices, need to be subjected to analytic validity and clinical validity before you get to the point where you invest in an outcomes measure. So in the last slide, I think, Dr. Kumar, you presented at least some type of framework that I think you believe should be what all of these technologies should be subjected to. I'm wondering if the rest of the panel agrees that that's a process that this cohort should embrace before we actually make a decision on pulling the trigger and implementing it.
I don't think there's any possible way to decide before you pull the trigger. This is the problem with modern rapid change technology. It would be ideal to figure out what works and how well before you ask somebody to use an app. But people are going to use the apps whether we ask them to or not, right? They're going to be using it or the sensor or whatever. And so I think we need to try and learn from the experience and discern what works and what doesn't as part of the overall goal, and clearly make that part of the new science. Not to say we shouldn't figure out what works, we certainly should.
Yeah, let me respond to that, because again, we're doing a mixture of these. So part of it is what Peter is talking about, and that is essentially releasing things, allowing people to use them, and then to study the use and to perfect things. But we also have a laboratory in our building in the School of Engineering where we do the bench testing that Sanjay talked about, a full exercise measurement testing laboratory where we can do gold standard assessment and testing. So we're doing that to understand we do side-to-side comparisons of things. So again, those of us working in this space are cognizant of this validity process that needs to be done. But we're also, again, aware that some of these things are out there and that they're going to be used, and that we can capture this information just through the natural history of use, and again, the broad analytics that big data can provide us. I mean, if you've got thousands of people using something and you can apply something like that, that really is a new method of inquiry. And I will tell you, I'm in meetings on a daily basis with data scientists and engineers who have very promising suggestions of solutions to some of this. So again, as a classically trained epidemiology-based person who really believes in what you said as far as the pathway, it's been an eye-opener to me to sort of stretch my approach on this to include this broader array of evidence and knowledge generation.
And the number of hands that I see, we're going to have to be fast on questions and fast on responses. So Mark, and I'll kind of try to bounce around and be fair across both sides. Mark.
Yeah, Mark Williams, Geisinger. There's Gary Bennett did a presentation at the Implementation Science meeting that NIH sponsored about 3 years ago, and it was stunning as he said, here's how long it took me to get my IRB approval to get my mobile device available for a study, and then he scrolled all the other diabetes apps that had come into the market, and there were probably 100 apps that had appeared. So that raised two questions. One is, I think it's going to have to, again, reflect on study design, that the traditional method of, approving things and going through this type of process is not going to be adaptable in this type of a setting. But the second issue, and Peter, I want to come back to, sort of where you think we should go related to the heterogeneity of devices, and clearly the heterogeneity and reliability of the data that's going to be out there. Are you seeing a suite of, underwriter-approved, laboratories-approved apps for participants in the study? Are you seeing a data group that says, well, here's the new apps that came out this week. We now have to see how we can map these data into our, what is your vision of how we can really deal with this, Wild West of apps?
I may be the blasphemy speaker here. I've got all, more degrees than everybody in my family combined, and but I think we care less whether the real glucose value is 128 or 132. I really don't think we care. It's okay to be off for the precision of any given thing. Right? My wife got all upset because the new digital scale was a little different than the analog scale, right? Obviously in the wrong direction.
Although if I can just comment, I mean, this came up with me because I had a glucose of 124. If it had been 125, I would have gotten diabetes on my problem list.
Yeah.
And so we use this imperfect precision all the time to dichotomously classify individuals.
But that too needs to change, because we're going to wind up, we're going to have to deal with the fact that different sensors give different data. The first part, because of my jitters problem, I didn't realize this, but the first time I put on a Fitbit, I put it on in mid-morning, and by the time I retired, I had over 17,000 steps, right? And we're trying to hope to get to 10,000. Well, different people are going to obviously behave differently, and what we really care about is their difference over the course of time and how that works with intervention. And if the 17,000 step people are discovered to have the jitzes, and the jitzes are discovered to relate to one or two genes, and the genes are discovered to relate to longevity, these two but not those four, it's that feedback loop that winds up being valuable to us. So I'm less concerned about precision. But to your point of Underwriter's Lab, I think yes. I think we need to move from a single-step FDA long, tortuous process, which I've been through, and it is horrible, especially in the it's as bad as hard as it is in the medicine world where you're giving people drugs. That clearly makes sense. In the app world, it clearly doesn't make sense, and so there needs to be something between snake oil and 5 years studied, right? There needs to be a little button that goes on that says promising and probably and not likely to cause harm, and that's it, right?
Real quick, Kevin. And then
But if I could say, in the context of this initiative, I think the more precise some of our questions may be, we might want to be more controlling, to use a word, and again, with respect to the patient engagement group, of the types of apps and the types of systems we would use for a period or a length of time. Again, our more classical research approaches, because that will be important. Sure. But to do this, we're going to have to engage really, really good designers to help us do this, because these apps have to match the quality that people are getting out there on their own. It is not your usual control group these days. It is just not. People are going to be using these things on their own. So I think that's going to be a very important thing, and I think we can do that. But again, across the broad population, as Peter says, this broader area of information that we can get, and to sort of normalize the data that we might get from a variety of things is a real possibility.
I think, maybe I'm less clear. I think for the trials that are intentional, we should design the studies appropriately and do them right, no doubt. But we're trying to have a birth to a new kind of discovery-oriented science, and for that we need to allow for discovery to happen. We need to allow for people to provide that data in all kinds of ways, because we just can't know ahead of time what way is going to work.
let's go to you, and then I'll go back over here.
Gwen Coleman from NIEHS. We've been involved in this kind of business from the beginning of the GEI program, and we have continued our work there by funding some validation studies with the technologies that we developed back in 2006, 7 through 10. And, you know, I think there's two pieces here that are relevant. One is, if we think that the sensor data will replace all other types of quantification of environmental factors, then we have to go down a very rigorous path that we're only started on to sort of reach that bar that I think Francis was alluding to. Does it really predict, or is it related to the health outcomes in a very rigorous and robust way? And that's important, depending on what the questions you want to ask as part of the cohort and ancillary studies. But I see it as another opportunity. Giving people information about their environment is both a community engagement, an incentive, a motivator, but it also gives them more information to change behavior, their own practices, to manage their health more concretely than sort of being in a vacuum of being isolated in a world of lots of data around where they don't know what to trust and what not. So if we can use these kinds of sensors to improve the health literacy of the cohort and the population as a whole, and then watch as a sort of an observational experiment what happens to people when they have control and power over this information, we will learn a lot about how that affects health and disease over time. If we want to do it in a very targeted, hypothesis-driven, interventional way, there are probably ways to pick sensors that we have more information about in terms of its reliability, reproducibility, and then, you know, use those intentionally in certain sub-studies. But I mean, we're very excited about, you know, making exposure data on all those things that you talked about a currency that people want, and we're seeing that, you know, it's happening in the marketplace anyway. So if we could provide the evidence base for sort of having people trust the data and understand the data, I think that that would be a great part of this whole preventative medicine initiative.
Any comments from you guys? Okay, Kevin, let's go back here.
I wanted to come back to Francis's question about the utility of these techniques and technologies. And I think fundamentally there's an opportunity here for this to be really the underpinning of a change in how we deliver healthcare. So if you think about the current model, I have lots of chronic diseases. I go to the doctor 20 times a year. Each visit is 10 minutes long. So I have 2 hours of FaceTime with the doctor. There's 5,000 plus waking hours where I'm on my own. And the physician has neither the tools nor the ability to monitor what I'm doing, measure what I'm doing, give me any feedback. So you create an ecosystem where suddenly you can do all sorts of layering of patient or physician behavior change interventions on top of the technology. And when you think about this in contexts like diabetes, you go from having a patient come in every few months, maybe remembering to bring their logbook, maybe not, and then talking to them and having them try to remember what their blood sugar control is, to an ecosystem where every day you get these sensor inputs. Through an exception handling process, you can filter that to the provider, who then can decide who are the patients in my panel who I need to pay attention to, as opposed to who showed up in my office. And a lot of the shifts in healthcare financing happening right now in terms of moving from fee-for-service to population-based financing are really going to accelerate the need for these kinds of technologies and the accompanying behavior change solutions. We've seen through a lot of carefully done clinical trials, you can improve people's blood sugar, you can improve their cholesterol, you can improve their medication adherence, you can improve their smoking cessation rates. So I think there's enormous potential, but it is going to be, as I think the panelists have highlighted, a central part of the future, and we have to figure out how to best harness that.
Let me pull that back to science and the research question, and the genetic one in particular. We really don't know what to tell most of those diabetics most of the time about what to do in the next hour. We really lack the fidelity of recommendations beyond lose weight, walk more, right? We really, we've got the real basics, but when it comes down to the how in your particular case, we really don't do a very good job of that. And it's because we don't figure out the in your particular case part. And that's where this crossover between precision medicine, between genomics and the interventional medicine really happens. We will, through this set of studies, figure out why that particular person would do better with this particular recommendation in that particular situation than her sister. And that's the kind of data that we're getting to. It amazes me how many times people in my extended family measure their glucose and do nothing with the result. They don't change their behavior at all. Well, why would you measure it if you're not going to change your behavior? It just doesn't make any sense. But we do because we're told to do. Right? We need to move from the place where we're gathering data to where we gather the data and do something with it. And in particular, we need to do that per individual, per problem, at a very granular level. That's what makes for costs to go down and quality to go up.
So let me, before I get to the next person, we want to make sure we don't conflate the sort of validity issue, right? The sort of, are our markers valid indicators of the phenomena from the intervention end of the spectrum, and do they actually do something to change health in some way? So those are kind of two separate questions, but let me go back over here.
Hey, thanks. I want to make 2 points. The first is the importance of a large existing cohort to be able to study these issues, and the second is the ongoing issue of regulation or non-regulation of these technologies. So I'm John White. I'm the acting Deputy National Coordinator for Health IT, and I've got a whole set of comments related to that role, but since Francis threw down the science chip, I'm going to slip that hat off and put on my regular hat, which is I'm the Director of the Division of Health IT at the Agency for Healthcare Research and Quality. So I've been funding studies in this area for about 10 years. What I'll say is that it's extraordinarily important. It's extraordinarily challenging. We all recognize the technology really evolves faster than the health outcomes, really, that we're interested in, which is why it really, to me, underscores the importance of having a large existing cohort that has information about the use of these technologies. So that's really critical. The second thing is that it's been widely discussed recently about how we deal with these technologies, because really you're talking about taking potential interventions out of the hands of clinicians, putting them in the hands of participants, as somebody said. And that's great. I think that's what we want. I think we also need to be able to, in a very informed and rational way, talk about what those effects are. So when the issue comes up of, should we be, and my colleagues from the FDA are the ones to talk to about that, not me. But I just want to raise the fact that that gets discussed is another critical reason to focus on making sure that this research is done and is done well. Thanks.
Comments?
These are
Alan,
great.
let me go here and then I'll go back.
I guess this is another utility question in a way, and would you agree that independent of the device or of the app, that the user, particularly the early adopter, will tend to think that much more of the data gathered are actionable than we in medicine would? And if that's the case, how do we bring those together, and how do we manage expectations of the users?
I don't know how we manage expectations of the people who read, RAG daily either. Most of what's told people is wrong in the press. And we've got to figure out how to put green and yellow and red stickers on some of that stuff as well. I can only come back to the communication goes better in the other direction as well. It's not just that they get the data, it's that we can tell them something about the data pretty quickly. And to the extent that people that this is a platform that's open enough for people to give the nudges back and give the answers back, that's not really that useful, is a perfectly good answer.
Yeah, and I would comment, I think that we're, again, in the early phases of this. This is just the first few years of quantified self and whatnot. But what's encouraging is that there are affinity groups that are developing. People are learning from others about this, and this is really an important aspect of this. We have patients like me in this meeting. We have others. So I think the expectations about one might either gain from or not gain from these data will emerge. Again, we as scientists want to use them for the purposes that we want to both understand and to intervene to improve outcomes. But I think, again, this past decade has been just so extraordinary. Again, in our health data exploration project for the Robert Wood Johnson Foundation, we're doing qualitative research to try to understand how people even think about these data. What do they think about their privacy? What do they think about their relationship with the company that helps them capture this? We're at the early stages of that. So again, concurrent with this cohort initiative, we can continue to feed in and inform processes over the next 5 to 10 years that I think will really advance, again, our knowledge, our understanding, and our use of these. But it's going to be a broad partnership between, again, when I talk about this, I talk about health-related scientists, engineering and computer-related scientists, and then the folks in design and human-computer world who help us understand how we as human species interface with these technologies and understand them.
Let me put a little word, or you said it, but I mean, the word that we use about that is I've got a little ditty, precision, big, SOMO, clo. This is the era we're in. We're about precision. That's what this meeting is about. But big data, social, mobile, and cloud is the technology era that we're in, right? And it's the social interaction that is likely to be enabled in a way that will cause interventions to happen to say what's valuable and what isn't in more local circles. Everybody with a particular version of myasthenia gravis with a particular variant will be able to get together and should be able to, with good permissions and good anonymity, both of which should be enabled by such a system. If somebody says they're a doctor, we can say for sure they are when intervening in a social circle, right? And if somebody says they've got myasthenia gravis type 28B, because we now know that, we'll know that that's true because of the precision piece of this. And it is the enablement that this group is trying to get to go that'll complement the social, mobile, and cloud pieces that are already out there.
Bill, just one quick point on this. So I think the point you raise is a very interesting one. So when we talk about engagement, there are two aspects to it. One aspect is, are we engaging them so that they remain interested in data collection? And if while engaging them to continue to adhere to the data collection, are we overstepping and trying to change their behavior and encourage them to take action that has not been validated yet? So that's something that we should be extremely careful about when we talk about engagement, that we should not use the engagement tool to encourage participants to take certain action that has not yet been validated. At least in this cohort, we as scientists, that's our responsibility.
Let me go back here in the middle. Yeah.
Hi, Ron Praskotsky. I'm fascinated with what you folks were mentioning about the Internet of Things, the little things that you stick on the walls, or thermostat and all that. You can identify if the person's actually using the medication or whatever, and having all that. And these are all the early adopters that we're actually talking about. Now, it makes me wonder to some extent, when you look at this and the dynamism that is going on with the mobile technologies and the upgrades, and you take also into consideration consent. How are we going to go ahead through consent, still not impinge on free will of these individuals that are part of this study? Because a small, 0.0001 modification of an app may actually get more information, and then you have a Havasupai tribe incident on your hands. What does have to happen?
Well, luckily there's 300 million people in the country, and we only need 100 million of them to volunteer, and we're going to ask them to volunteer at a broader level of consent because of that issue. We don't have much choice. If part of it is voluntary submission of data, then they're obviously consenting to what they volunteer to, right? And the particular trials should be well controlled and well consented.
It's true, but on the other hand, in that situation, are you also setting up yourself for bias? Because you're getting persons that will use this technology that are financially enabled to use this technology that, oh, by the way, are not amputees, so they can't wear this watch, and all the other conditionals that really may not address that one particular issue that you're trying to find.
Well, I think we're going to have to be careful about that, and I think we will probably have to subsidize some of the aspects of participation in this if, in fact, we want to truly representative cohort. We've done that in some of our studies. Our NIH-funded studies found it well accepted. There has to be sort of retail work with individuals, working with them to sort of get a sense, not a wholesale approach, because one size doesn't fit all. Again, we've been successful with that with low-income Hispanic populations in our community in San Diego. So I think these are solvable problems. I am excited about this notion of volunteers, though, and this notion that people really are willing, and both eyes wide open, to come into this and participate, become a member. I loved that discussion yesterday about being proud to be a member of participatory research. So I think that's important, and I think we may be surprised at the power of the social network dynamics. And again, I'm not just talking about Facebook social networks. I'm talking about Promotora social networks that might exist in, offline in Southern California, about getting people really engaged through their churches and through other areas to sort of say, hey, there's this fun study that's going on that we all might benefit from. And so I think, again, we know these things can happen. We know we can work with the appropriate staff and community members to make this happen. And so I think we can reduce the concern, probably not completely, but to reduce the concern that you raised. That's a very valid one about bias.
I know a number of you have been patient, but I know Pearl is probably still on point with this, so go ahead.
Yeah, thank you. I think you're absolutely right. IRBs are having a very difficult time with this. And a lot of the concerns are there are so many, quote, apps out there. There's almost apps overload, and people are doing it for their personal benefit / entertainment. And when it suddenly goes into a research realm, the concern is, how do you actually inform someone so they realize it's not just giving me my stuff, but it's actually going somewhere else? And the concerns that we've had is secondary use of the information. How is it used? How do you let people know how it's used? As you talk about going from maybe a church or an institution, there are going to be institutional identity issues that have to be also addressed. And the other huge issue is security. I mean, I think we've heard over and over again, privacy is gone. To say we can de-identify virtually anything seems to be a yesteryear event.
Let me do the security piece briefly. I think that one of the projects that Verizon got going on is something we call universal identity, which is organized around making strong identity and strong anonymity both work in the same system at scale for hundreds of millions of people. So this is the idea that you could say that someone is a doctor for sure, or they've got myasthenia gravis for sure, but you can't, but their name and social security number, all those other things are not available. Obviously, someone, with 3 bits of information could ultimately dial it down. But this platform needs to provide, and I like the sort of API notion about it, it needs to provide a set of tools that are used by this cohort and available to others that lock down the basics of privacy, security, and permissions. That just needs to be part of the platform. Just like TCP/IP and ping and other parts were the platform of the internet. We didn't use them all, right? But certain of them rose to the top as being essential, and we use them. So we need to decide what those basic platform components, and they clearly include some security and identity and privacy and permissioning things, need to be part of that. And they will obviously grow over time.
So let me just add a little bit to what Peter said. I think we need to, when it comes to this cohort, at least that we will, that we have a collective responsibility for, there should be a substrate or at least a middleware or software in the mobile phone that subscribes to the notion of responsible computing, which is that any data that leaves from the mobile device, it should clearly have permission of the participant as to who are the recipients and what that's being used for. And anytime there is a deviation, the people should be informed. And this could be enforced at the participant level by appropriate software research.
So I've realized I've allowed us to move from validity and efficacy into the consent and engagement into the spectrum. So those of you who have specific points about that can raise so back here in the back.
So this is a couple of comments there. They go into both consent and validity and accuracy. I'm thinking about observational studies and this idea that they replace clinical trials with the observation on estrogen and osteoporosis. And unless you really fully understand the universe of potential variables when you ask a question, you still run the substantial risk of attribution, misattribution with a correlate. So I don't think you're going to replace the need for a different kind of design. It might be a prospective observational study, but still you may need some randomization. Secondly, I think I heard some comments about adherence. And adherence is, of course, a huge issue in clinical trials in general, and the way we typically have dealt with that is by use of an intent to treat design in which we don't try to correct for non-adherence. You randomize people out, and they adhere or they don't adhere, but it tells you about the real world, and it gets you past some of these other potential sources of bias. And it also, in the realm of consent, it actually increases autonomy as well, because it doesn't make people really agree to anything other than participation, but you're not, really hitting on them hard in terms of whether they are adherent or not. And so I'd just like to, make those observations, and then two others on management, and since we've got a large cohort. Complexity and scale. Complexity in a study on a small scale can be hard to manage. I imagine the management complexity of very complex studies, and this could be very complex on a large scale, is going to create both financial and management challenges. I'm sure that Francis is having to think about this. I'm glad I don't have to.
Let me just say one thing about the management complexity. It's that we should take some comfort from the fact that we all, several 100 million population in this country are able to have their devices with them. It works most of the time. So if we can borrow from practices of the software corporations that are able to manage millions and millions of customers or millions and millions of devices without having face-to-face time, and with automatic updates and automated data collection, that could come back to help us manage this complexity.
Yeah, absolutely. I was going to make a comment because, again, being involved in small studies with lots of moving parts, it really is complicated. But we're dealing with self-report measures when people come in every 6 months for their measurements. And we're dealing with the occasional phone calls that might occur. We're talking here about continuous contact, continuous engagement with individuals through simple things like text messages or through a study-focused app. So this notion, and we have much more precise information thereby, continuous information about adherence, non-adherence, who needs a phone call, who doesn't. So this, again, this is a problem, but it also has, as Santosh mentioned, a real exciting solution that we can borrow from industry and do in a very interesting way.
And on the notion of controlled studies versus observational, I completely agree that controlled studies are currently the best thing, and they're never going to go away. Observational gives you the clue of what the hypothesis will be, and the controlled study figures out if it's, exactly what the detail is. What we're thinking, though, is that, what's 23andMe, what's your current population of submissions? Does somebody just yell it out?
We have 850,000 people.
Yeah. So, we already have 1 million people, more or less, right? Wouldn't you like to have that data, too, to look at? Right? If it just happened to be available, don't you think there's going to be another 8 or 10 million people that do this, whether we ask them to or not, because it's interesting to them? And even though that data may not have the precision that the full genome sequence does, I think we might say, golly, if that data was submitted voluntarily to those guys and it's available and I can compare it to this data and do some query-oriented science to make my hypothesis better, then that's the platform we're trying to enable, and to improve both the prospective clinical trials and the observational stuff.
So Rod's been patient, so let me.
Yeah, so patient that we moved off the topic we're on when I first raised my hand. So I want to return to the general area of efficacy, and specifically the topic of identifying points of intervention. I think it was yesterday when Rory Collins asked a question or proposed that we should be able to identify a declination in health. And Peter this morning began to introduce the concept of moving from smartphones to smartwatches to smart homes. And if we explore the development of smart homes, I think we'll have the opportunity to have an even more integrated data set and assessment of the patient or participant as a whole, and identify areas that might signal points of intervention. The types of things that he showed are beginning to be used in a study that we've been supporting along with the Aging Institute for the last couple of years, aimed at developing smart homes to specifically assist the elderly in healthy, independent living. And these homes are outfitted with a variety of sensors, some like what Peter showed, an additional sensors. And the data's still early, but what seems to be emerging from this are some algorithms that are quite sophisticated, looking at second-order effects, not just to whether you go in and out, but looking at time differentials of those sorts of things. So rate of motion, or rate of movement, pattern of movement, changes in acceleration even, sort of third-order things, which begin to indicate how well a person is functioning and maybe even indicate things like cognitive decline. These algorithms can identify not only what room you're in and where you are, but what you're doing in a room. If you're in the kitchen, or you're cooking, or you're eating, or you're washing dishes, those sorts of things can appear to be decipherable from these sorts of algorithms. So I think that holds out hope that we could begin to see early indicators of cognitive decline or physical decline that might signal to the provider, this Kevin Volpe was referencing, that here are some people that need to come in and I need to begin to look at more closely. You got any comments on this, Peter, yet? Have you operated in this space?
It's clearly the goal.
I do, and I think, again, this is beautifully said, because this is exactly what's happening. We have brought an entire cadre of engineers who've been doing this in manufacturing and in signal detection and whatnot. And over the last few years, all you have to do is look at the proceedings of the Wireless Medicine Conference that Wendy's been involved in and that others held here on the campus at NIH this last year, and I think to be held again. The extraordinary ability to find these signals, I mean, the notion of predictive analytics, which many of us have talked about for a long period of time as a preventive medicine physician, is actually becoming real. We are finding these things. Deborah Estrin, an extremely well-known engineer at Cornell Tech, talks about her father's life trajectory before he died, and had only she known how constrained it got because of the traces. If she could have been able to capture the traces of his life over the few weeks before he passed away, she would have been able to intervene in one way or another. So there's just an extraordinary amount. And again, I think it's our job as experts in this area to bring this to the table in this particular cohort and make sure that we're using state-of-the-art technologies, validating them to the extent that we can. And also, I would say, borrowing from the broader pools of data that are being gathered outside of this cohort.
Francis, did you have?
It's a different topic.
Also, before we get to a different topic, Wendy?
So I just want to, I'm Wendy Nelson from the Office of Behavioral and Social Science Research, and I just wanted to say there's two ways to think about this, and there's the discovery piece, which I think we've really been focused on, these broad data collections around that. But there's what the work groups talked about, a lot of this stuff has algorithms already in there. It's, activity using these accelerometers, sleep. These are, the self-reports, using measures like PROMIS, which have been developed at NIH. These are pretty well-known issues. They're pretty well-known. They've been validated, many of them. Most of them are very close to being validated, if not. There's that, so there's the easy win now, capturing these things, and then there's this discovery science piece, which I think then broadens this discussion, which seems to be where we focused on this big piece, but I don't want to have everybody forget the smaller piece that we can do now. And there are a lot of sensors that are being developed and validated. I think my colleague at NIHS made a great point, but if we have a cohort like this, we can validate these much faster, and we don't have to give people the data as this is gospel. The data comes in as we're trying to make sure this works. Would you like to work with us to figure that out? So I think that then you don't have to have that, then the concern about people, rushing off and saying this is it, is a much, much better way to think about it.
So specifically on the point of validation before we move on then? Are there other things related to that we need to address?
I do want to highlight in the discussion, there seem to be two visions for the cohort that are in inherent tension. So is this basically an observational study to determine the genetic and non-genetic causes of disease? Or is it an intervention study where basically it's a pool of volunteers for clinical interventions of the sort that's being talked about? Because those are totally different things, and there's an inherent tension between those two.
I think it's a platform to enable prescriptive, intentional, clinically controlled, standard sort of trials based on genetics and phenotypic crossover, and a platform that enables a future of new science. And that's why this room is here, because the opportunity to accelerate people selection and controlled trial selection and get down to precision understanding of which person, to find the 20 people with a particular, microphenotype that you need that matches your particular genetic anomaly. This can help that and find that out. At the same time, it can enable the transition in medicine. And the first is the goal of, and the funding and all the rest. The second is the opportunity that makes this foundational.
Yes, I'll just add a little bit to that. Yes, I agree that we have different visions. I would at least articulate my vision, is that as we begin this, if we could be in that observational phase, and as we learn more from this data, and as we conduct those appropriate trials to assess the efficacy, then the same cohort could begin to receive the benefits of the same study itself. Finally, I would say that as Rod was talking about yesterday, if this study indeed gets a culture in the country and around the world of participatory medicine, that people begin to participate in their own medicine. So that means the lessons we learn from this precision medicine study, especially if we assist and prove the efficacy, could be then translated over to everybody who is interested and would like to participate in such an effort. And then we truly will get a precision medicine culture in the entire country and in the rest of the world. So this precision medicine initiative, I believe, is the right platform to get us a start from the observation and then move into intervention and then into translation to the rest of the human population.
So I have to add my 2 cents to this, because I think 10 years from now, we're not going to be saying either or. I think this is an opportunity to move from an either-or to a systems view on this. And I think what we're talking about here is setting up the situation in which we can have gene, drug, behavior, and environment studies that talk about the interrelationships between all of those things. And I think the complex interrelationships between those things, including the social environment that we talked about, again, I mentioned this morning. So all of those things interact with one another in a highly complex systems way, and all are becoming atomized, digitized, and this is really, at the end, a big data challenge. So we've got to marry this to the big data initiative that has also been stood up by NIH. And it's an exciting time because, again, as someone trained in classic epidemiology, a classic approach to studying populations, but who moved into interventions, I've always sort of been dealing with that divide, and I'm excited about the notion that we're truly moving to a much more systems approach.
So before, I know many of you have been very patient, so hang on, we'll do David, because I know that he's on point on this, and then I think we have something online that's probably also on point, and then Dan, Erwin, a lot of you I see, so I'll get to you. Go ahead.
Don't forget Francis.
Thanks. David Murray, Office of Disease Prevention here at NIH. So we're all familiar with how much work goes into cleaning data from observational studies, from clinical trials, lots and lots of time and effort when we use standardized protocols and standardized data collection procedures. You guys are describing what to me is a completely different universe of use any app, use any device. That's going to generate an extremely heterogeneous stream of data with different variables measured in different ways on different frequencies for each person potentially in the cohort coming into a cloud somewhere. And I'm not sure how to deal with that, but hopefully you've thought about it, or our big data friends have thought about it. How do we harmonize all of that and generate data that we can use in the research?
So I think we have NIH to thank for it. So I would thank Dr. Collins, Dr. Philborn, and all of you from NIH that we have Big Data to Knowledge initiative. And as part of this, there is a very sustained effort to do this analytics, screening, cleaning, and visualizing, analyzing, and interpreting mobile health data. So we believe that this effort, supplemented by several other efforts, will get us there.
So Allison, let's let the online people have a shot here real quick before we go back to the group.
So from the web, we have a question that brings us back to more foundational issues that must be addressed on this topic. Not everyone can afford a smartphone. If smartphones become a requirement, don't we risk skewing the patient sampling?
So 85% of everybody has one right now, a smartphone, and 65% of everybody who's older has one. So for those people, we don't need to worry about it. They've already got one. They're not terribly expensive. We can get smartphones in people's hands for on the vicinity of $100. And I think if we need them, we give it to them. That's just the way it is. By the way, the community of people in the watch and smartphone business are very interested in making things like this work. And I don't think we're going to have any problem getting the vendors of these devices and platforms to participate.
But again, it's worth stating, it's not just having the phone. It's having a phone that's usable, that one can see, that if one has arthritis or other problems, one can actually use. So again, paying attention to how we provide these in the context of this study will be important. And as I mentioned yesterday, there are some wonderful folks that we can work with who are helping us solve the problems of making sure that we essentially have the reach across the entire population.
I'm going to do Eric real quick because I know you're on
I
point. and then
I was
Erwin and
interested
Dan,
in
you
this.
next,
I'm
too.
glad someone asked this. I was wondering the same thing. Is there any, have there been any studies to show any systematic biases in the individuals who don't have? I mean, you gave percentages, had the majority, most, but what about the, are there any systematic bias introduced by
I thought you were going to say iOS versus Android. There must be some data there. Which gene drives you one way or the other?
I'm not aware of any specific, and there may well be, I'm just not aware, but I will, as an example, for example, our GPS-related research, so GPS either in a phone or a separate device, we have had challenges using this in the border population of San Diego with some of these Hispanic populations that we've been working with because of concerns about anonymity and identification as we go through and we tell them what we will know about them and what we won't. So this is actually in the context of a validation study that we're using that Gwen mentioned for our PALMS project. So yes, we're finding these, we've reported out some of the qualitative findings at meetings and whatnot, and so we're digging into these. And I think, again, the family of people working in mHealth are very cognizant of these issues because most of us are driven by this passion to make sure that these work for as many people as they can, including children. I mean, one of my colleagues is doing work on children and chronic disease and whatnot. So again, it continues to be an evolving and emerging field that good people are thinking about.
So, and let me just add to that. I mean, in the early days of the internet, right, we were concerned about the internet divide and the digital divide. That socio-demographic divide doesn't seem to be the case with pretty much most of the feature phones and to a lesser degree now with smartphones. So we know that's also the case. And I've also, if you go to any homeless shelter, they only have one device. It's probably a smartphone, right? Because it's the one thing they know they can carry that connects them to the internet. Erwin, you've been very patient, so.
Thank you. Urban Bodinger, Mount Sinai Health.
I was in line before you.
Yeah, that remains to be determined. But so we accept the proposition of big data as a platform and to enhance what we can do with the cohort that we're talking about. And we've talked about validity issues. We've talked about issues of the person, the participant, and all the safety, privacy, and et cetera. So can we shift the thought for a moment to what would be your thoughts on an initial demonstration towards utility? Just a hypothetical argument about exciting a study section to say, okay, this is great because with this data specifically, we might bend the curve on an endpoint that is very relevant for health outcomes.
So I'll give two examples of this utility. So none of which has been done yet, but both of which are being pursued right now. So as part of the MD2K Center of Excellence, there are two biomedical applications that we are looking into. One is smoking cessation, and being able to use continuous measurement of stress, measurement of smoking cues via eyeglasses, measurement of geo-exposure via GPS. Can we predict smoking lapses? And if so, can we design sensor-triggered just-in-time intervention that can be adapted to the person so that when they are most vulnerable, can we trigger an intervention that can help them continue to be abstinent? That's one. Second is for congestive heart failure patients, what we don't have is a non-invasive method to be able to monitor the progression and prevent rehospitalization. And there is a sensor that we have developed, that our team has developed, which measures the lung fluid congestion on a continuous basis, and we to use that in order to predict and prevent rehospitalization. So we don't have results from any of that, but they give example that right now we are in the process of trying to evaluate and demonstrate clinical utility of these mobile devices.
Yeah, and what this is involving is actually the connection between the physiological measures, the geospatially characterized measures of where someone might actually get a meal that's too much sodium for their congestive heart failure, to the behavioral measures, to the interventional measures, to the cognitive things. So this involves lining up a variety of things. And again, for purposes of the cohort we're talking about, imagine if we had a deeper understanding of the genotypes of these individuals to know who might either respond or not. So again, these are potential home runs, we think, about connecting the dots between the layers of influence on health.
Dan, you've been waiting so long, I probably owe you a beer, but go ahead.
Thank you. I'll get it from Erwin, it's okay. So Dan Roden from Vanderbilt. I have three comments. So I started my professional career as an arrhythmia doctor, and I will say that the arrhythmia field has been interesting because we were one of the first to generate large sets of data that no one knew how to interpret, and we immediately assumed that because the rhythm is abnormal, therefore it needs to be treated, a really, really bad assumption. So I share Francis's worry that we're implementing before we know the risks and benefits of that implementation. That said, I think one of the early wins could be screening very large numbers of people who are totally asymptomatic to find patients who have atrial fibrillation and therefore are at stroke risk, a hypothesis that needs to be treated, but needs to be tested, but could be an early win because the technologies are in place. That was actually all prologue to the comment that I wanted to make, and that is, it seems to me we're talking about these kinds of technologies in two different ways. One is gathering data that will contribute to health care, and the other is engaging participants. And I didn't hear much about the engaging participants part in the talks, but Rory will tell you that they engage the UK Biobank by email once every so often, and we'll hear later how that works. But it seems to me that we could, every participant could get a one question a week.
Yeah.
That would not only keep them engaged, but also might make the data sets richer. And I wonder if, new models of consent, for example, could be deployed this way. So while I'm a little nervous about the healthcare part of it, I think that there's tremendous opportunities to engage, and again, I'll say it, millions and millions of patients, not a million patients, in this kind of effort, using this kind, and the only way to do it is using this kind of technology.
And one of the reasons for the recommendation for both a smartphone and a watch is that I've worn a watch. I'm up to 6 different smartwatches I've worn. The one thing that's true about them all is that they're right there, right? And it always surprises you when the watch does something. I had my phone ringing the other day, and it was my watch that was ringing, and I kept looking for my phone. But the watch can be a very pervasive and immediate intervention engagement model. And it doesn't need to be a text message. It certainly could be a text message, right? But it could be something graphic. It could be something that has many other different forms. So the feedback possibilities there, and indeed the sort of micro iterations of the consent can happen through engagement.
So I would like to thank Dan for making that suggestion. I think we should include that in the recommendation. Also, I would like to tag along from another suggestion is that just like we have patients like me, I would envision in this precision medicine cohort something like participants like me. That means if we can build the right community that, so that it's not just our questions that they are answering, if we can observe their activity, we do not even have to bother them to find out whether they're engaged or not.
Yeah, and I would comment, just as almost everybody here is looking at a computer screen and checking your phone and whatnot, I think once a week is so not 90s, I would say. In our obesity research with garden variety, overweight adults, both full English, full Spanish language speakers, the happy medium with respect to numbers of text messages a day that they wanted to both receive and respond to were 2. We would start from anywhere from 1 to 5, and these are messages that they would respond. It had been basically an expert system with thousands of messages, 2 per day, and they were happy with this if you looked across a year's worth of views. So
One of them is, when you pick up that big bag of potato chips, right?
There's a lot of hands in the back. John, I'll start with you, and I'll kind of work my way back up.
So, John Wilbanks from Sage Bionetworks, just sort of one comment, which is that we've been working to launch 2 observational studies that are mobile only to enroll 100,000 people in each study. And I can tell you that the culture of building these apps and the people who are good at building them is not a health culture. Whether it's how to get informed consent, the tension is always going to be to make it faster, shorter, less informing. When it's about what data to gather, the instinct is always going to be to gather more data. And the example I'd give you is GPS. So we're doing a Parkinson's study. Part of what you want to do is measure mobility because it's a good proxy for depression. You can either scrape the raw latitude and longitude off the phone, which has some massive privacy issues, or you can keep a pin on the phone where it's encrypted and just measure the delta of the person's movement over the course of the day. The app developers don't ever think about the second one because in cultural apps, you can grab whatever data you want without any consent. And so there's going to be constant tension as you build these apps between trying to implement the norms of health and the taste of gathering the data you need to analyze and know more, and the sort of culture of the developers to just grab all of the things. And these have impacts even outside after you launch it, because it's not just the phone, it's the data plan. A lot of people who are going to give us the diversity we need to make this an actually useful cohort have monthly prepaid data contracts. And if you're choosing to gather all the data things, you're going to blow their data up. So we have to be culturally contextual in the way that we do this to understand the app developers don't know how to make health apps. And a lot of people who are going to install these health apps don't necessarily have data plans or sensors on their phone that are capable of doing everything. So this is part of community building and governance. It's not just sort of tech on phones and then everything's fine.
Let me help you with a technology solves your second one for sure. There is a capability among the carriers now to do what we used to call a Watts line, for those of us who have gray hair. It is possible and reasonable and appropriate and expected for the people who create such a study to pay for the data in a plan, and no matter what and that's now technically doable, right? Yeah.
Bill?
I just want to emphasize, so I'm DJ Patel here with NIH, and I'm a data scientist, and I've built a lot of these systems at large scale. And the thing I want to emphasize is the need to actually very actively engage with the companies that are building these sensors and these technologies. In large part because they're not thinking about this. They're thinking about surviving tomorrow. They're not there. And part of that is, what does it mean to actually get the data out of those systems, different formats, et cetera? We know, for example, if I put data on a page, the more data I put on the page, the less engaged you get. You're inversely proportional in your interaction with the amount of data that's presented. So how do we actually create and foster that relationship with industry to say, hey, here's where we're trying to go? Because the amount of data that's going to come off of this, the amount of innovation that's going to be there in terms of the sensors, the devices, the iteration, we can't even imagine what it's going to look like in 5 years. And so I just want to emphasize having that tight-knit collaboration.
It boils down to APIs. Go ahead.
Yeah, no, I think this is great, and it's actually why the Robert Wood Johnson Foundation funded the Health Data Exploration Project to begin to engage researchers and companies. And I think we're breaking the ice a little bit on this. I would welcome the opportunity to pull the NIH into as a partner on this, because you're exactly right. Jawbone, Fitbit, Google, Facebook, or whatever. These companies have their own approaches, their own strategies. But we found actually, and again, it's not the company. We found very willing people inside each of these companies who are very keen to help, to sort of figure out ways to do this. And of course, we then have to work through all the issues of access and ownership and the privacy-related issues that have been alluded to. But this is going to be part of the heavy lifting of this project. And I think, again, we've got to start, work at it, and I think at the end of 5 years, we can have made some serious inroads on this by the time we really begin to test the utility of this cohort.
If we can get the patriotism piece that we talked about yesterday, or whatever the Uber the drivers are, infused in this project, and I think that's a requirement, by the way, that we work. It doesn't have to be patriotism per se, but it has to be something that's greater than my good. If we get that infused in the project, then you wind up with this capability where the company who may resist sharing their data, or may resist putting it in a particular format, or who may resist making it more secure, or who may resist doing hashes of geo instead of getting all geo, or any of those things. If we say, if you want to deal with this community, you're going to do all the things I just mentioned, right? And here's how those APIs work. What's going to happen is that the users will vote. Right? The users will go to the people who are more aligned with the greater good, presuming we get the message right and get it out there right. So this is rising the value of this up high enough so that people want to participate and they want their vendor, their Fitbit, or whoever it is, to make their stuff compatible with the APIs or the structure or the policies that this group requires.
So Lucilla, since you've been up for a while, let me...
Yeah, first I would say I agree with everyone, even when they have opposite opinions. and I love technology, and I think this is a great idea. And I also think it's an opportunity to think away from exclusion criteria, and people who don't have it, don't want to have it, they should be included if they want to participate. So I think we just need to watch out for not, proposing we pay for your data plan now, but that's not going to continue later on. So think away from the observational study or clinical trial exclusion criteria. And in the end, I think just like in the 1,000 genomes, we'll end up with many more than 1,000. And here's the same situation.
Agreed.
So Francis, we have about 10 more minutes, so.
Well, I wanted to ask the panel why it is that now we've been talking about this for 100 minutes and nobody has raised the R word, because I was under the impression that that was actually a source of considerable anxiety, namely regulation. If we are contemplating a circumstance where all of these mHealth apps are getting developed and rigorously tested, we hope in a kind of platform where you find out what works and what actually improves outcomes. And then ultimately, I would imagine you want to introduce those more broadly, having learned from research what works and what doesn't work. Where does regulation rear its head, and how much should we be worried about that getting in the way of these dreams that we are all throwing around the room quite freely here?
So as long as we stay in the, as long as companies or anybody who puts out something out there that's not meant for diagnosis or treatment, they are not under regulation. In terms of making claims. So when we talk in terms of scientists who are working in this mHealth, we haven't put out a lot of evidence out there for companies to make use of and in filing for. So that's why many of them stay in the world of fitness and wellness and not get into disease management or treatment. So I would expect that as we progress towards treatment, intervention, behavior change, or improving outcomes, then that we start to move towards the regulation, and that there be a clear regulation pathway for people to make use of. Also, I would expect that the data that will be collected in this cohort will address the key concern that we have with evaluation of mobile health technology. The key concern is technology moves too quickly, and the evaluation will take so much time that by the time we are done with evaluation, technology will be outdated. If we have this kind of cohort, then it should improve drastically improve the time or reduce the time it will take to conduct the evaluation and hopefully keep the technology dated or updated.
Yeah, and I'd comment two things. One, I think the way the FDA has approached this to date, this general space, has actually been very good in this notion of this dividing line between those devices that are meant to have medical applications and those that are in this other space. So I think that has been good. There is a concern, and this is a concern that several of us see, that the personal health data, because again, the data are the important thing here, the personal health data derived from various devices, wearable technologies and whatnot, some people are trying to say that that should be covered under HIPAA because it's somehow in the HIPAA frame of reference. Those of us who are working in the personal health data space think that that would be a big mistake, that it would really constrain, as HIPAA things have constrained other things for some of the research we've done. So that's something many of us are keeping an eye on, and a potential regulatory thing that would go in the wrong direction to promote the kind of research that we're talking about across this broad cohort, especially if we're talking about bringing in federated data sets that relate to both the purposeful stuff that we're going to collect using our apps and the broader lacunae, the broader lakes of data that we can use for comparative purposes that are out there that are not HIPAA-oriented data. So we're keeping an eye on that in our project, the Health Data Exploration Project, and I think I would encourage the group to keep an eye on that as well.
Regulation is a big problem. It not only, I spent 20 years worrying about helping companies get compliant with things like HIPAA, and it's a big deal. HIPAA was, the guy who wrote HIPAA, Bill Braithwaite, works for me. The original intent of writing the regulation was to make it easier, not harder, to do privacy and security. It was written in a general way that said, do good things, do a risk assessment, and then do the right stuff. Unfortunately, people don't like general stuff. They're much better off with prescriptive things than sort of open-ended things like that. So HIPAA wound up being more problematic than other regulations like PCI, where here are the 12 things you need to do, and here's 1,000 people that can check the box whether you did or not. Having said that, I think there's sort of three related problems here. One is the security and privacy related things. I think the platform needs to be organized in such a way that if you use it, you are safe. I realize that's way beyond easy, but I think we need to make services or APIs sort of things that if you use them, they're designed to include the notion of privacy and permission and whatnot come with the service, right? And we've done some prototypes of that at Verizon. We've done some things at some scale there too. It's certainly achievable. That invites people to use it, because if they do use it, then they don't need to worry about, for example, HIPAA, right? The second one is the question of, is this device sort of the FDA question? It's separate than the privacy question. And for that question, I've been burnt several times in my career. It's really, really hard. And I think we're a little overboard on how FDA relates to things like apps and devices. So I'm suggesting that we probably need some certification, some seal, some check mark that is way less than FDA, that says it's not snake oil, but I can't tell you much more, right? That's all I can tell you, is it's not likely to cause harm, and it's probably not, it's got promise, but I can't tell you anymore. And I think we need that intermediate check, and we need to enable some mechanism to, maybe it's group method of figuring that out, scientists vote or something light and quick, that just gets the notion out there that this one is promising and not likely to cause harm. And we need to be able to adopt and endorse those things.
So just a 10-second point. So if I mentioned the hurdle of the time it takes to conduct evaluation, and that's a bigger hurdle why companies or those who are putting out apps, they are not able to do evaluation. The other is cost. I believe if we can launch this cohort and make it available for testing the efficacy of mobile health devices, that could address both the cost as well as the time.
So, and I also know, the FDA had its mobile health guidance out, and they've been trying to stay ahead of this for a while, and I think I actually saw this morning some additional guidance about smartphones and that sort of thing. On regulation specifically, a couple other points.
Hey, it's John White again. All right, so now I'm going to put the ONC hat on. ONC has some regulatory purview in this area. We issue the certification regulation for health IT. When you start getting to mobile apps, you're getting beyond. But ONC also has a role in standard setting, working with all of our federal partners around the table, NIH, FDA, many others that are here. Certification the approach has largely been focused on meaningful use. I think that as meaningful use changes, that will change as well. For standard setting, and this gets a little bit back to some of the privacy issues that were raised earlier. I think ONC has not been focused necessarily on a regulatory approach, a non-regulatory approach. We have a draft interoperability roadmap, which is out for public comment, and a companion piece to that is a standards advisory, which is draft at this moment, but that we're looking at issuing. And we think that that's hopefully a nice approach to be able to indicate on a more frequent than regulatory basis what the best available standards are, where there is consensus. There's not always consensus, of course. And to be able to point to that so that folks who are doing regulatory work can indicate that. The final piece that I would say in terms of keeping up with this and resources in terms of how it evolves is patient-centered outcomes research work, which many of the people in the room have been involved with. But in addition to the funding that happens through PCORI, there's another stream of funding that comes through the department related to that for data infrastructure and standardization. NIH has been involved with that. ONC has been involved with that. So not to get into the detail, devolve into the details, but I think that that's a resource also to be looked at to build on. Thanks.
So any comments from you guys before we wrap?
Ditto.
Ditto.
Go ahead.
I know I'm looking at time. I just looked at my watch and realized it's down here on the podium. So we're at 10:30 at the break. So we can certainly do discussion during break as well, but let's have a break for 15 minutes before we pick up. Thank you all.
Thank you.